So my name's Simon Glover. I'm the interim patient flow strategic lead, and I was also the lead nurse on the Healthier Patient Pathways project. So I work here at Greater Manchester Mental Health, which is a trust that covers both Central Manchester, South Manchester, North Manchester, Bolton, Salford and Trafford. So we provide the mental health related care for people across these areas. I think first and foremost, it was mostly around capacity and access to inpatient beds. So we provide secondary health care, and we provide all the inpatient care for adult mental health. And that was the remit of the project. So what we had was a particularly challenging time in terms of access to inpatient beds in a timely manner. And what we wanted from the project was to reduce the length of stay for people who came into hospital, so we didn't have any wasted bed days, to improve the quality of care that people were receiving, and to reduce down the amount of out of area placements, because it's not ideal for any of our service users to receive their care further away from home. So we wanted to try and increase the capacity within the system so we could have more timely admissions, and also ensure that we weren't using out of area placements so people could be treated within their own locality, because that obviously improves access for carers to visit people where that's allowed. Obviously we're in difficult times with COVID, but obviously visiting has been increasing over recent times. Sure. And of course being able to link back in with the local community and the local services that they might be receiving from community mental health teams, etc. I think the main challenges were timely access to inpatient beds, and it's looking at the whole system really. So it's not just the admission perspective, but that's something we did focus on as part of the project in terms of looking at that purpose for admission and making sure it was absolutely required in terms of an admission, or whether we could get some genuine supportive alternatives in the community. So we're always applying those least restrictive principles at any one time. Then it was looking at the day-to-day workings on the inpatient units as well, in terms of how timely people were receiving things like their weekly MDT review, looking at the board rounds and making sure all areas were standardised and using one sort of version of a board round across the system as well, making sure that our patient flow practitioners that work within each division, that support flow through the system, had a good way of managing and having oversight of all the service users at any one time, because we wanted to just make sure that we were challenging all those barriers to discharge. That's probably one of the most significant things we came up against, was just our timeliness around resolving those barriers and then aiding that flow through the system and back out into the community again as well. I think with any project like that, I suppose you always perceive that every staff member's working the hardest that they can. So it wasn't about how hard people were working, it was about how efficiently people were working within the system that we had created for ourselves, and whether we were getting the best out of that. And I suppose there's always that worry when people come in externally and having a look, is that they don't quite understand the pressures of the system, and it's all very much geared towards data and numbers, and not looking at things, not applying it practically to the situation. So I think they were probably the fears that you'd have with any sort of external company coming in and then having a look at how things are working. So that would be providing that gold standard level of care for service users and carers, looking at the well-being of the staff as well, and then looking at how we created that capacity within the system, which we know at times can be a really challenged system in terms of flow and availability of beds. So it was looking at how we were able to reduce that length of stay, and also how we could reduce down the detox. So detox are delayed transfers of care. So anybody with unresolved barriers and being able to move on to the next stage of their care and being stranded on that kind of inpatient setting. And also looking at reducing down the out of area admissions as well. So we could bring people back and get care back in their own localities. Well, I think having to sort of mentioned before what the fears were, obviously none of those concerns came to light really. What we did have was a project put together by one of our associate directors, and that project was a really big piece of work. It had 5 work streams, and then within those work streams it had more areas to cover as well. And what Meridian brought was we had Laurie and Chris working on the project with us from start to finish, and they were brilliant. They were really well engaged in the project. Laurie had the oversight in terms of the project manager, and he brought loads of project management skills into the mix, and he was able to keep everything really well organised, coming up with really good ideas around sort of lean principles and ways of working. And we all worked together really well as a unit. So we had Chris, who was in the background, pulling together any metrics or reporting ideas. We had Laurie with oversight of the whole project, keeping everything really well organised. And then we brought in our own quality improvement team to support with that. I came in as the lead nurse with that sort of clinical background. And then we had John, the associate director, who pulled this whole project together. They're just kind of continuously driving things as well in the background. And yeah, it was a really, really positive experience. What they brought in terms of those project management skills and being able to engage the staff wasn't just your kind of typical, I suppose, what you would imagine from a productivity company in terms of working in that background, looking at things from a manufacturing perspective, and then just trying to bring in different measures and processes, because mental health doesn't work that way. It's it's an ever-changing sort of shifting scene really, with all different types of challenges. But what Chris and Laurie were able to do is adapt to that really well, and take on board all of those pressures. And yeah, just really impressed with how hard they worked as well. They were over here in Manchester, stayed in a hotel, always sending out emails up till 10 o'clock at night, trying to get the next presentation in order, because we were delivering to our own board, or we're delivering to a quality improvement or some other area, or CCGs were interested in what we were doing, so we're having to adapt all the presentations all the time. It was just keeping things well structured, because we had a lot of planning events with staff on quite a big scale, in order to bring in the quality improvement aspect of the project. And then, for example, that was with the Perfect Week, which was probably the biggest part of the project that we did. And then what we do is meet with all 6 divisions and then run these planning events, get the staff engaged on the ground level. So it wasn't like I just mentioned, that sort of productivity aspect where you're just looking at numbers, figures, and then bringing in measures. It was engaging staff, training staff around lean, getting staff's ideas around quality improvement, change ideas that they wanted to bring into the situation, and then looking at that from a sustainability perspective. So each time you finished with a division, you still carried on with them, even though you moved on to the next division to start something different and do the next part of the project. You were still keeping them engaged to make sure the key change ideas were being well embedded into the service. So quite a big scope of work really, quite an achievement. Yeah, it's something that's a well-established idea that's used primarily with acute trust hospitals, and it's very much geared towards creating flow within the system, challenging some of the ways that we think about how we do things and trying new ideas out really. What we did slightly differently was with ours has brought that quality improvement aspect as well. So first of all, the Perfect Week is just 1 week of bringing the whole system together within that division, and then looking at what the pressures are, whether it be from an admission perspective right through to all the barriers to discharge, and engaging all of our external partners as well as CCG, local authority, bringing all those key people together from an MDT perspective and really trying to drill down in some of those complex cases and move things forward. But what we also did is brought in the quality improvement element, so we'd bring in new ideas as well of how to make the system a bit leaner, or new ideas just to do things better than we were doing previously. And by engaging the staff on the ground floor, it's them that brought the ideas. So then what we would do is create a PDSA cycle around those ideas and embed them in on the perfect